Thank you. On behalf of the co-authors, their study teams, and patients from many centers around the world, it's my privilege to share with you the results today of a week 24 cross-study comparison from two single-arm studies. What these studies had in common were they're in treatment-naive adolescents, single-tablet regimen. The integrase inhibitor elvitegravir was part of the backbone. What differentiated these two studies was the prodrug formulation of tenofovir. In one was tenofovir, disoproxil, fumarate. From here on, I'll call it TDF. And the other was tenofovir, alafenamide. From here on, I'll call it TAF. And the focus of the presentation is on the renal and bone parameters, especially the bone, which is of interest to the pediatric and adolescent care providers. As a short introduction to the difference between TAF and TDF, TDF metabolizes to tenofovir primarily in the plasma, as opposed TAF primarily metabolizes to tenofovir intracellularly. Resultant, the difference in the footprint of tenofovir in the plasma is remarkable, with as less as 90% lower presence of tenofovir in the plasma when TAF is used as opposed to when TDF is used. And tenofovir levels have been correlated in the plasma with bone and renal side effects. This forms the premise for the expectations from TAF for lower renal and bone side effects. There are two single tablet formulations which have this combination of elvitegravir, cobicistat, M-tricitabine, and then either TAF or TDF. With TDF, it's the commercially available formulation called Stribil, and the TAF containing preparation is in the research environment. These two formulations were compared head to head, and the results published from two phase 3 double-blind studies in Lancet earlier this year. And the key take-home points there were in non-inferiority of the TAF-containing formulation compared to the TDF-containing formulation, and significantly reduced renal and bone effects. The same formulations are being studied in adolescents 12 to 18 years of age, and we have previously shown that these are well tolerated, and then the plasma level of all components are comparable to adults. These are the formulations that were used in the two single-arm studies, results from which we'll be discussing today. They were both very similar in study design, both for 48 weeks with an allowance for an extension phase as needed. Primary endpoint safety in adolescents and in treatment-naive patients. Besides routine safety assessments, there was a focus on renal parameters, including renal tubular protein biomarkers, as well as the use of dual X-ray absorptiometry, also called DEXA, done at baseline, 24 weeks, and every 24 weeks thereafter. Of importance for pediatric adolescent comparisons was that height-adjusted Z-scores were calculated. At baseline, I'd like to point out in this slide to some key differences. The TAF cohort was slightly younger, slightly more females. 60% of the participants were from a site in Uganda, and then with slightly lower height-adjusted Z-scores. All of these were statistically significant differences. Also of note was that 64% of the participants in the TAF cohort had a vertical transmission as mode of infection. So these were patients who were with vertical transmission, untreated, and first treated around 15, 16 years of age. This may have bearing on interpretation of bone and renal data, given the long-term exposure to HIV. In terms of patient disposition, what we discussed today are the week 24 results, and at that time point, the data collection for all enrolled subjects is complete. Starting with just looking at efficacy, it was comparable for both at week 24, with 90 and 88% respectively achieving an undetectable viral load. From a safety overview standpoint, no deaths or adverse events leading to treatment discontinuation. And then, relevant to today's presentation, no cases of proximal renal tubulopathy or Fanconi syndrome. Only one treatment-related SAE, and that was intermediate uveitis, which resolved while the patient continued to remain on treatment. So starting with the renal section, looking at glomerular parameters, and shown here are creatinine, and serum cystatin C. Creatinine, slight increase, 0.08 milligram per deciliter in both cohorts, very comparable. And as you know, the cobicistat influences creatinine secretion in the proximal tubules, so does influence, can influence some of this. A cobicistat independent glomerular parameter would be the serum cystatin C, which showed a slight decline, again comparable between the two study arms, between the two studies. Switching to renal tubular biomarkers, which are of interest, specific with using tenofovir and following patients on them. 3 urinary urine proteins are shown here, and to orient you to the slide, all of these are the protein to creatinine ratio for the respective markers. On the y-axis is the median % change from baseline, with the quartile 1 and quartile 3 flanking the parameters shown. And on the x-axis are week 8, 12, and 24. What you'll see for most of my slides are in purple the TAF cohort results, and in orange the TDF cohort results. That'll make it easy to follow through. So the theme here is that across the 3 urine protein markers, there was a reduction that was seen in the TAF cohort. There was an increase that was seen in terms of urine retinol binding protein to creatinine ratio for the TDF cohort, and a slightly higher urine protein and urine beta-2 microglobulin to creatinine ratio compared to the TAF cohort in the TDF cohort. Of all of these, the only one which achieved statistical significance was the week 8 comparison for the urine retinol binding protein to creatinine ratio. These results are with a smaller sample size in a smaller time frame, but are very similar to the phase 3 results, where with a much larger sample size at week 48, these differences were much more accentuated and statistically significant. Looking at bone, orienting you to the slide and how the results have been put together. Again, on the y-axis is the median % change from baseline with the quartile 1 and quartile 3. What's shown first is what would be the predicted change in bone mineral density, taking into account the age and gender and normative data, which was based from CDC collected normative data. And then again in purple is the TAF comparison. So compared to the predicted, and walking through the first comparison at week 24 for the cohort and its gender, age, demographic composition, a plus 2.55% change from baseline with a 1.11 to 4.54 as in terms of quartiles is what would be predicted. And what was actual in terms of the DEX assessments was a plus 1.25 with a minus 0.96 to 4.11, so slightly lower. The same comparison for TDF shows a much more striking difference in terms of predicted to actual, with the actual being minus 1% change from baseline at week 24 and ranging from minus 3.57 to plus 0.95. This difference in between the TDF and the TAF arm was statistically significant different. Also, at week 24, when looking at proportion of patients who had a 4% or more decline in BMD, spine BMD, compared to baseline, it was 7% in the TAF cohort and 21% in the TDF cohort. So while being cognizant that this was a cross-study comparison, and there were differences at baseline in age, gender, mode of transmission, we note that both groups exhibited a rapid virologic response and a high rate of virologic success at week 24, and overall the regimens were well tolerated. And given that from a renal standpoint, there was a slight and what would be an expected rise in serum creatinine with the known effect of cobicistat. And there was a decrease in renal biomarkers, which I had mentioned was very reflective of the changes that were seen in the larger phase 3 studies. And there was noted a median spine BMD increase at week 24 for the TAF cohort by 1.3% median value, and a decrease of -1% in the TDF cohort. These data suggest the continued use of both of these formulations, but add to what is a growing body of literature which suggests potential renal and bone safety advantages of TAF, and is of particular relevance to the growing bone in pediatric and adolescent patients. I again thank the study teams and the patients and their families. For those who are following the TAF story as it relates to the renal and the bone, I would like to point out to two presentations tomorrow, one looking at a switch study design but with a focus on the bone and the kidney, and the other in patients with renal impairment. Both of these are in adult patients. Thank you.
Thank you very much.